Hello and welcome to your mini lecture on Chapter 3, which is Assessment and Diagnosis. I have divided the chapter into these two components. Assessment is really going to be the big part of this chapter. I want you to understand it really well. Your case analysis that you'll be writing for next week, for the second week of class, is over sort of assessment, so I want you to understand what these instruments are and sort of how they differ. There's a couple other components in the chapter, so make sure you read those, but I'm going to focus on assessment in particular today. So I have up here sort of all the different types of assessments that we use as clinicians in order to do a couple different things. Primarily, we use assessment to try to diagnose people. And the reason that we want to use assessment to diagnose them is that we want the diagnosis to be accurate. We also use assessment in order to make sure that we're doing what we should be doing in terms of our treatments. We also use assessment to determine the prognosis of an illness, whether it's likely the person will recover or not recover, things along those lines. But assessment is primarily connected to diagnosis. And here are the different ways we do it. So the first one that the book really talks about is this idea of screening. Screening is a type of assessment where we're not leading directly to diagnosis. We're simply getting together some people and we're saying, hey, do you want to know if you're at risk for mental illness? Screening is meant to be primarily preventative. So there are actually different days within the year that we have, like called National Depression Screening Day, that's in October. And so sometimes at colleges you'll see where there'll be people around and you take a really quick instrument and they'll say, hey, you're kind of showing some signs, you should probably get checked out and get further assessment to see if you have depression. So screening is mostly preventative. We want to catch people before their illness gets too bad. The rest of these we would primarily use in a clinical setting where somebody has come in and said, hey, I think there might be something wrong with me, can you do an assessment, and then we'll go ahead and assess them. So almost always, for just about anyone that we see, we're going to use a clinical interview. That clinical interview is basically where we first talk to them and sort of figure out what their history is and also figure out what's going on with them right now. We can do it in two different ways, a structured or an unstructured. A structured clinical interview means that there's already a list of questions that the clinician's going to use. So no matter who you are, no matter what you say to me, I'm going to make sure I cover this whole list. Unstructured means that I kind of have an idea of what I want to ask, but I'm going to follow you. So if you say something, I might ask a question about that, and my questions are going to be different depending upon the person. Both of them have advantages. In a structured interview, you make sure you get all the information that you need so you can have a clear diagnosis. However, sometimes the person is sort of offset because they say, hey, I didn't say anything about depression, but you keep asking me these questions about whether I'm sad. In an unstructured interview, it can be advantageous because you build what we call rapport with the person. The person really believes that you're trying to follow them, you're trying to understand them well. However, sometimes you might miss asking a question that the person doesn't bring up that could be important to diagnosis. So those are structured and unstructured clinical interviews. We almost always use them. Psychological tests, and there are lots of them, we would use these for various reasons. Personality tests you may be most familiar with. So these are tests that we use to determine sort of who a person is in terms of their personality characteristics. Some of the common ones that we use, the book talks about, is the MMPI. So we give you a paper pencil or a computer MMPI, and it's about 500 questions, and based upon the results of that, it kind of alerts us to let us know that this person is high on certain traits. And then these traits might correspond with certain diagnoses. Projective tests are a little bit different. You've probably heard of the Rorschach ink blot test. That's the most popular one. So we'll give you something that's sort of ambiguous to look at, and we'll say, what do you see in this picture? And then you'll tell us what you see. This really is tapping into this idea that you're going to project your unconscious onto that ambiguous or that little ink blot, the thing that doesn't really look like anything. A lot of people in the psychoanalytic field will use projective tests because it comes from that Freudian psychoanalytic model. So that's what it would tell us. It would tell us what's going on in your unconscious, but it doesn't give us a lot of strong information in terms of diagnosis. We can also use general psychological functioning tests, and there's a couple of them out on the market. In particular, the most popular one is the GAF, or the Global Assessment of Functioning. Based upon sort of where you are, I would give you a number between 0 and 100 to say how you're functioning. The lower your number, the lower you're functioning. So that can be really, really handy if I just want a snapshot of sort of where a person's at, but it doesn't really do anything to help me diagnose the person. Neuropsychological functioning tests are if there's something I believe is something's wrong in the brain. So maybe you've had what we call a TBI, a traumatic brain injury. You've fallen down, or something else has happened that might have caused damage in your brain, or you've had a tumor, or we think you might have a tumor, those sorts of things. So I would use those, particularly for people who are having problems with memory, or attention, or other cognitive issues, and I could pinpoint what exactly the issue is. So that's where we use neuropsychological functioning. Intelligence testing we would use if we believe that part of what's going on might have to do with your intelligence. So we might be thinking, we use this a lot with children, if we think maybe they have a learning disorder, or we believe that they might have autism or IDD, which is intellectual developmental disorder, those sorts of things. We want to make sure that we want to rule out if there's any intelligence issues, and we want to, or rule in if that's what's going on. So that's how we would use intelligence testing. And there's a huge history in intelligence testing in psychology. And again, my Psych Lab has a couple of different videos you could watch that talk about that a little bit. We could also use what I call what the book calls behavioral assessment. So instead of us doing the test, we're going to directly look at your behaviors. We can do that two different ways. We can have you self-monitor. So I might ask you to, if you're dealing with anxiety, every time you feel anxious, I'm going to ask you to write it down and sort of journal about what happened but right before, what happened right after, and how high that anxiety was. And then you'll bring it into me and we'll have sort of a log to say, okay, you seem to be anxious in these situations. With children, it's really hard to do, so a 5-year-old's not going to do that. So we use a lot of direct behavioral observation. So I would have them sort of come into the lab, or I would show up to their playground, and I would just watch them interact with others, or interact with toys, or interact with their parents. And by watching them, I'm going to be able to sort of get a good feel of what's going on without them having to tell me. So that's behavioral assessment. The very last one is the psychophysiological assessment. We would use those if we believe that there's something physical that's connected. So we use it a lot with anxiety disorders because anxiety is all about the physical. So this is where I would use like EEGs, or I would use galvanized skin tests to kind of see like, how heightened you are, or heartbeat or temperature or things like that. Sometimes those are connected. There's a good section in your book about biofeedback. We use biofeedback quite a bit, and that falls under the psychophysiological assessment. So these are all the assessments that we use. There's a lot of them. You really want to spend some time understanding the differences between them, when you would use a personality test versus when you would use a neuropsychological functioning test. Because they're not all appropriate. We do not do all of these every time a person comes in. That would be ridiculous, unnecessary, and it would waste a lot of time. So we pick and choose from this bag which ones we want that we believe would be helpful in that particular situation. The other half of this chapter, or it's not even a half, it's probably about the last third, is all about diagnosis. So make sure you look at the history of diagnosis a little bit. We've had 5 different editions of the DSM. The DSM is the Diagnostic and Statistical Manual. That's what we use to diagnose individuals. I'll have to remember to bring a copy of it for maybe the next video so that you guys can see what it looks like. But the very first couple DSMs, we started in the 50s, 1956 I think is when the first DSM came about, and they were very descriptive. So they just described mental illnesses. Depression looks like this. When we got to the DSM-3, which was in 1980, we moved to what we call a criterion-based system, where instead of describing them, we said, okay, if you're going to have depression, then you have to have 6 of the following 9 symptoms. That's criterion-based. That's what we've been using ever since 1980. The DSM-4 changed a bit. It added much more cultural and environmental issues. We were concerned not just about whether you had symptoms, but how the environment or your culture might impact them. So we became a little bit more what we call holistic. We are right now in the DSM-5 version. That came out in May of 2013, so just 1 year ago. By October of this year is when it has to be implemented by all clinicians. So by October, everybody will be using the DSM-5. We now diagnose on these three sort of axes, or these three criteria. You will use these three criteria in your case analysis, and you will see them over and over and over again in your case studies. So that's why I want you to understand these three criteria. The first one is the actual clinical disorder. So once I have assessed you and I go, you have depression, I would then put major depressive disorder as your clinical disorder. You could have more of them. That's what we call comorbid. So you might have major depressive disorder, and you might also have PTSD, post-traumatic stress disorder. All of the disorders will go in that first line. The second line is we try to consider if there's any medical issues that are going on that might impact it. So if you have asthma, that's important to know. Maybe you have a vision issue where you can't see. If you're blind, that's an issue. And maybe that's contributing to some of the major depression that you are experiencing. So any medical issues will go in that second line. And the third line is what we call environmental stressors. So these are things that may also be impacting them. So let's say you got divorced recently. That's certainly going to impact whether or not you have a mental illness. Maybe you were raped. Certainly that would be connected with PTSD. Maybe you are simply having trouble in school, so we call it academic problems. That would go on that line. So this is how we diagnose people. We don't just look at what their clinical disorder is, but we also look at what's going on medically, and we also look at what's going on in terms of their environmental stress. So that's a nice background on diagnosis. Again, you're going to use some of these models over and over again in this class. So if anything doesn't make sense, make sure that you're contacting me and understanding everything before your first exam. Excuse me. Your first exam is due the second Sunday of the course. I think that's June 15th. Double check the calendar on that one. And it's over chapters 1, 2, and 3. So if you have any questions about those, make sure you ask me before that date. Good luck on your first exam, and I'll see you in the next video.